today's session, I'm going to do vascular ultrasound, focusing mainly on above knee DVT. Okay. How many of you have started doing vascular diagnostic vascular ultrasounds?
Yes, I did one last week.
Okay. Right. See, it's actually extremely easy. Echo is the one that is the most challenging. All the other modalities, and maybe lung to some extent for the, from a conceptual viewpoint, but every other modality, abdominal, including renal and biliary and vascular, are extremely easy. Vascular ultrasound is particularly easy because you guys do it for vascular access all the time. So in this particular session, I'm only going to be talking about the diagnostic aspects of DVT scanning. So vascular scanning, venous ultrasound scanning for the purpose of DVT. Number one, there's nothing procedural in this. Second, I'm mainly going to be focusing on above knee DVT. And the reason for that is because above knee DVTs account for 90% of pulmonary emboli. So if you have below knee DVTs, a lot of the time you'll only monitor them, but you won't actually anticoagulate them. You won't treat them. Similarly, the clinical significance of upper limb DVTs is also disputed. And particularly in patients where you have relative contraindications for anticoagulation, it's not uncommon for us to just leave upper limb DVTs. Obviously, the more proximal the DVT is to the heart, the greater is the likelihood that it will embolize, and therefore you'll have a lower threshold to anticoagulate. Now, even though I'm not going to cover the scanning technique, etc., the principles are exactly the same whichever blood vessel in the body you are scanning. So therefore, there's no reason why, if you, with a little bit of a knowledge of anatomy, you will not be able to scan any other part of the body for DVT. Okay. Now, so focusing on the lower limb above knee DVT, there are two important veins. Okay. One is the common femoral vein, and it's at the saphenofemoral junction, and the other is the popliteal vein in the popliteal fossa. You'll notice that I have skipped the parts in between. And the reason for that is because in an emergency situation, it is reasonably clear if these 2 points are clear of DVT, and these 2 points. So if there's no DVT at the saphenofemoral junction, and if there's no DVT at the popliteal vein, there is almost a 90%, 95% specificity saying that you're not likely to have a clinically significant DVT in between. Okay. However, scanning in between is actually extremely simple, and therefore I will be covering that in there. So scanning the femoral vein in the thigh I'll also cover that in today's session. So these are the 2 points that I was talking to you about. So this is the common iliac vein here. This is the groin crease here, and you have the common femoral vein, and the great saphenous vein joins that, and this is called the saphenofemoral junction. So this is the common femoral vein. This is the deep femoral. This is the saphenous vein, and then it will join together to form the saphenofemoral junction. Okay. Sorry, just going back. The vein then it keeps coming down as the deep femoral vein goes here. The superficial femoral vein goes and becomes and joins into it finally becomes the popliteal vein posterior to the knee. So we will be scanning this whole segment, and we will also be scanning this particular segment. I will be briefly touching on how to scan this area, but this is not something that I routinely concentrate on, and I don't do that many scans of these. Okay. How do you identify the femoral vein at the inguinal crease? So just at the inguinal crease, so if you draw a line from the pubic symphysis to the anterior superior iliac spine, along there you're going to have the vein, artery, and nerve in a van configuration from medial to lateral. Okay, so it will be like this. So you have you'll have the vein, artery, and nerve, but we are not focusing on the nerve. We are not. Andrew might be doing a scan of the nerve for femoral nerve blocks, and the anatomy is exactly the same. As far as we are concerned, the configuration that we are going to look for is the relationship between the femoral artery, okay, and the 2 veins of our interest. Okay. And as I said, vein, artery, and nerve is from medial to lateral. So this is the right side. So vein, artery, the nerve will be somewhere here. But lateral to the femoral vein, medial to the femoral vein, you're going to have the long saphenous vein. Now, this is called the Mickey Mouse sign because it looks like the Mickey Mouse. The important thing, however, is that there is a discrepancy between the ears of the Mickey Mouse sign, and I'd like one of you to comment on what that discrepancy is. It's not an exact mirror image, and what is it?
This is the shape and size.
Okay, I've drawn it that way. So no. What else? This communicates. Okay, the long saphenous vein drains into the common femoral vein. So when you're scanning, you will see these two structures, the femoral artery and the common femoral vein, as two distinct structures. And these two will actually be communicating. So this wall there's no wall here. Okay, this long saphenous is going to drain into this. And when you're putting Doppler, color Doppler, you'll actually see that there is free flowing communication between these two structures. Okay, so that is an important distinction because it is not uncommon for you to have the probe rotated left to right. And therefore, it is not uncommon for people to mistake the femoral artery for the long saphenous vein and then say that it is not compressible. Okay, I'll tell you the probe orientation and all that a little bit later, but right now we are talking of the anatomy. Okay, so same thing here. You have the common femoral vein. The long saphenous vein is entering into it. This is the common femoral artery. Okay, a lot of the pictures that I've taken today are from Radiopedia and from YouTube. Okay. Now, in the popliteal, for the popliteal vein is posterior. It is in the popliteal fossa. And as far as anatomy is concerned, it is posterior to the popliteal artery. But as far as ultrasonology is concerned, because you are scanning from posterior to anterior, the popliteal vein will be the more the more superficial structure. Okay, so if you keep your probe transverse in the popliteal fossa, you will be able to see the popliteal vein, and then you'll be able to see the popliteal artery posterior to that. Okay. Now, what are the principles of DVT scanning? The first thing is that so these are the important things that you look for, and among these things, the most important two things are these two. Okay, echogenicity and compressibility. These are ancillary things which radiology sonographers will do. It is not difficult to do, but there are a lot of fallacies to this. So mainly 99% of your diagnosis is going to be based on 2D imaging, which is looking for the echogenicity within the cavity of the vein and the compressibility on pressure when you're applying pressure to the vein. Okay. And the distinctions between a normal vein and DVT are, a normal vein is completely anechoic, whereas a DVT may have an echogenic material in the lumen. The reason I'm calling it may is because it is not uncommon for fresh thrombi and small thrombi where the echogenic material may be missed. The other reasons why echogenic material may be missed is because of gain. A very common thing that beginners do when you're scanning, this is regardless of which ultrasound modality it is, whether it is ultrasound of the heart or whatever it is, gain is always very, very high. Typically, we have a hyper gained setting. And if you have that, the echogenic material will be missed. Similarly, if you have a very low gain, again, you're going to have the echogenic material will not be identified. So when you're setting the gain, you should always compare it to the adjacent artery. Okay, so if you have if everything looks, if there is an excess noise everywhere, every structure appears echogenic, then it clearly means that it is the gain setting. It is not a DVT. So that's the first thing, the echogenicity. Then the next thing is compression on pressure. Okay, a normal vein should be fully compressible, and the operative word here is fully. When you're applying pressure on a vein, regardless of whether the patient has an increased venous hypertension. If the patient has right heart failure or something, and their CVP might be 20 or 25, even then you should have a full compressibility of the vein. You should be able to flatten the anterior and the posterior walls absolutely together so that they kiss each other. On the other hand, a DVT is either completely not compressible, or only a part of it might be compressible. How much pressure should you apply? You should apply enough pressure to distort the adjacent artery. Because if you're applying pressure to so even if the patient is hypotensive, I would suspect that the systolic pressure will be at least 65, 70 to 80 or something. So if you're applying that much pressure, you're not going to have any situation where your CVP is going to be higher than a systolic of, an arterial systolic of 60 or 70 or 80, even in a hypotensive patient. So if you have applied enough pressure to distort the artery and the vein is still not compressible, it clearly means that there is something anatomically stenting open the vein. Okay. Now these other things here, which are so these the Doppler modalities are an ancillary thing. Okay, there are a number of fallacies to it, but in general, if you put Doppler and have it and reduce the scale for venous velocity, you'll have uniform filling of the vein, whereas a DVT may have a filling defect. Again, the operative word is a may, and the reason is because angle dependence is a very big thing. You know that if you are perpendicular to the vein, which you are almost always going to be, then your Doppler might not be you might not have filling. However, when you're choosing the vascular ultrasound settings, there is an automatic angle correction that is applied by the machine. The other thing you can do is that you can change the angulation of your transducer such that you create a 30 or 40 degree angle to the vein in order to get the flow. Then you apply pulse wave on the vein. And what you're looking for here is in a normal vein where there is a full communication between the anatomical point where you're scanning and the entire vein all the way up to the heart. So in this instance, if the IVC is fully, if there is no anatomical occlusion between the right atrium and, in this instance, the femoral vein, for example, then you'll have the cardiopulmonary variations the pressure variations transmitted all the way to the femoral vein or even the popliteal vein. So how will that manifest? You will have respiratory variations in velocity. And whereas in a DVT setting, you might not have a respiratory variation, okay, if there is a proximal occlusion, especially a particular proximal complete occlusion. On the other hand, and then the other thing that you do is you look for a distal augmentation. So if you apply pressure on the calf and you change, look at the velocity, then you will have a significant augmentation of the velocity in a normal setting. Whereas if you have a DVT that is in between your calf pressure point and the vein that you're scanning, it may not augment. This is, however, not advised because you may have a risk of dislodging a clot and causing a pulmonary embolus. Okay, and of course, that's a different way you can get a diagnosis, but not the best way. Okay. Do you have any questions so far? I will be going into the technique. Zone and with pictures. Do you have any questions so far? All good? Okay. The sequence of venous scanning. You always should start with transverse or 2D scanning, and you look for the 2D compressibility and echogenic material within the vein. After that only, you have to put color Doppler, looking for color filling within the vein. You're still transverse, and then still transverse, you do the pulse wave, and then you change to a longitudinal direction, wherein you look for the echogenic material, etc. But what you do is you do not do compressibility, and you often don't do pulse wave. The reason, can anyone tell me why I say it is not a good practice to try and do compressibility in the longitudinal position? Longitudinal scan transducer.
And you easily just like move your hand and you actually like look at not the vein and artery.
See, when you're transverse, okay, if this is the vein, okay, and you're transverse, then the entire vein is going to be on under the probe, and therefore the pressure is going to be applied all across the vein. On the other hand, if you're going to be longitudinal, then you might slip off on one side or the other, and you might, especially if it is not uncommon, and this, remember that this is a slippery slope, the thigh is a slippery slope, okay, and you have gel on it. If you're applying pressure, it's going to slide down. It's very common for it to slide down laterally, even by a centimeter, and you will lose the vein, the plane of the vein completely. But what you might mistake it as, that it's fully compressible, because I saw a vein before and I'm not able to see the vein now, and you might mistake that. So this is actually a technical issue. So do not attempt compression in the longitudinal plane. Okay, right. Now, all of these, you have to do it at multiple levels along the limb. Okay. Now, this is an example of a normal finding wherein you have the this is actually the artery and vein, and here after you apply compression, the vein completely occludes. Okay. And that's another important thing. When you are applying compression, if your machine settings allow it, it is a good practice to choose the dual mode on the machines, wherein you have the pre-compression view on the left side and the post-compression view on the right side, and you can take it side by side and you can take a picture of that. The other important thing is that I like doing it as a video, saving it as a video rather than as a still picture. And if you're going to save it as a video rather than a still picture, then you don't have to have the dual mode. You can just have a single picture on the screen, because you're actually showing the dynamic compression happening in real time, and everyone can see how much it is compressed. And at the end of the compression, if you maintain the pressure for some time, you can clearly see, everybody can see that it's fully compressible or not compressible. Okay, this is an example of a color Doppler thing. Now, forget the red, the red and the green, the red and the blue. Which one is artery? Which one is vein? It's a trick question. Which one is artery? Which one is vein? No one's answering today. Have you all had lunch? Is red the artery and blue the vein?
So no, it's a longitudinal view. It all depends on the probe orientation.
Exactly. So as far as the blue and red convention is concerned, the typical convention on ultrasound is blue away and red towards. So this thing here, okay. So you are looking at this scale here, and if your probe orientation is such that the flow is coming towards the transducer, then whichever structure that is will end up being red. And if the probe and anything where the blood flow is going away from the transducer will be blue. So therefore, do not mistake, don't think that red and blue colors are different. Okay. Now this is an example of the color Doppler. Okay, this is a flow in the artery. This is a flow in the vein. Okay, and the flow in the vein in this particular thing, you can clearly see that between this and here, between here and here, there is a significant variation, and that might be the phasic variation because of respiration. Okay. Now, what are the findings in a DVT? If you have echogenic material within the vein lumen, so can you see here? You can see that faint echogenic material, and you can also see that echogenic material here. Whereas within the artery, you can compare the gain within the artery to see whether you have overgained or not. And in this instance, it is not overgained. Okay. Then the lack of compressibility. See that the artery here is now oval compared to, it's clearly distorted here. And so there's enough pressure to distort the artery, but yet the vein is not compressing. Therefore, clearly, these are the two important signs. And if you have this is a almost 100% specificity that you have a DVT within that vein. Okay. So when you have the echogenic material, always compare with the adjacent artery. Then you can put color Doppler That's an ancillary thing, but always start doing it and look for the false positives of increased gain. Now, the next false positive is about mistaking a lymph node for a vein. Okay, if you have a lymph node, then it will look exactly like this. Okay. What is the big difference between a lymph node and a vein? A lymph node will always be circular in any plane that you scan. So if you rotate the probe 90 degrees to the transverse plane, so if you get a longitudinal view, if it is a vein, it will always become, it will become long and tubular, whereas a lymph node will remain circular. Okay, so this is an important distinction. So this is another fallacy with DVT scanning that you'll have to identify. Okay. Then this is an example of a lack of augmentation in, this is normal, whereas here there is very little flow. But the thing is, I'm not going to dwell on this. Remember that augmentation as well as the pulsatile, the phasic variations with respiration are not absolute. It depends on the actual pressure generated during during ventilation or during the augmentation, and therefore you do not rely on these for confirming or ruling out DVTs. There are no normal values for normal venous velocity, etc. At least not that I have read anywhere. If any of you read it, and please pass it on to me, because it changes from patient to patient and depending on the preload and depending on the ventilation settings. So continue. I keep re-emphasizing these are ancillary things. The most important is 2D findings. Okay. So as I said, 2-point compression is what you're going to look for. You're looking for the 2D findings, or is the you're going to look for the 2D findings of the femoral vein and the popliteal vein at the saphenofemoral junction of the popliteal fossa. You're going to look for echogenic material within the vein, and you are looking for compressibility. And then the ancillary tests are these things here. Okay, echogenic material, femoral vein, is it compressible or not? And finally, in the mid thigh or not? And is there color Doppler filling, augmentation, and phasic variations? Okay. Now, this is the technique. I'll explain this and then I'll show you a video here. Okay. Now, is this part of the screen also being visible? Your faces, everything? It's also, is that all? Can you see these as well? Should I get rid of that?
Don't know what you're pointing at, Arvind. We can see the slide.
No, you can see the slide, but can you see your names and all that as well?
No.
Good.
No.
Okay. And can you see the word externally fully,
Yep.
including the LLY?
No. Oh, yeah.
Can you see the LLY as well externally?
Yeah.
Good.
The slide's
Okay,
coming
that's
fully.
fine. Good, fine, okay. But like for me, the Microsoft Teams window is minimized there. Okay. Now, how do you scan? The position of the patient is you can have if it's an ambulant patient, people often they sit in a chair or they're reclining. Typically, all our patients are going to be in a bed. They're going to be supine. Okay. For the thigh, it's very easy. You just keep the lower limb extended, slightly externally rotated, and that's for your comfort, so that you can scan all the way from the saphenofemoral junction, going in a medial direction, posterior-medial direction, until you reach the popliteal fossa. Okay. The probe that you choose is typically the vascular probe or the linear probe, and choose the vascular setting on it. However, if you work at Nepean Hospital and when you have our patient mix, the vascular probe may not be enough. You might need to have the curvilinear probe, which has the same characteristics as the vascular probe, but the depth setting of the curvilinear abdominal probe is you can scan a much deeper depth. And with if you have our obese patients, then choose that probe instead. Okay, particularly for the thigh. For the saphenofemoral junction and the popliteal, you might be able to get away with just the vascular probe even in obese patients. But always select the vascular ultrasound setting for the preset, because that will also have angle correction and all that for color Doppler. Okay. Then 2D mode, the probe must be transverse, and you always have the probe marker facing the 9 o'clock position, regardless of whether you're scanning the right or the left leg, because that is going to be your anatomical thing. When you're having 9 o'clock position, then it means that for the you can have the orientation that way, and this is something that you must do even when you're doing vascular access. Okay, then you place it below the inguinal crease, perpendicular to the skin. Identify the Mickey Mouse sign. You have to move the probe so that the vein, the common femoral vein, is always at the center of the image, not the artery, not the saphenous vein. Okay. Then once you have identified the Mickey Mouse sign and have centered the probe over the common femoral vein, then you have to press the vein firmly in an anterior-posterior direction. A very common error here is that because it's a slippery slope, when you're applying the pressure, it is common for you to change your probe orientation, and it will become, instead of anterior-posterior, instead of being absolutely perpendicular like this, you might end up angulating the probe towards the heart or away from the heart, and that might end up causing the pressure transmission might not be entire to the vein. Okay, so press the vein firmly in an anterior posterior direction. The femoral vein must compress or flatten completely. The saphenous vein must also compress completely. Okay, the anterior and posterior walls of the veins. When I say completely, what it means is it must literally, the anterior and posterior walls must kiss each other. Okay, you must not have any gap whatsoever. Okay, now this is a YouTube video. So what you do is, this is the common femoral vein. This is, see how much it's compressing here. So during the compression, now here, I'm actually not happy with this. You can see a little bit of a gap here, and I'm not happy. You actually have to apply even more pressure so that this completely flattens. Okay. You have, okay. So, and you can do it as a video, and you can demonstrate this as a, you can demonstrate the flattening of the vein in a video. I always like choosing it as a video and complete compression. But see this here, they have not actually taken the trouble. You still have a little bit of a gap, even though they see that gap there. Okay, that gap must not be there. You have to compress such that you have the entire thing compressing. Okay. Now, what do you do next? The next thing you do is to apply the color Doppler, and one minute. Okay, so the next thing, you can slide the probe in a chordate direction along the femoral vein. So what you do is you apply gel all across in a straight, in a broad, a line going from here, typically posterior-medially. I would actually put the gel somewhere here, and then what you do is, without removing the probe, without taking the probe from the skin, you have to follow the vein. Okay, so I'm going back. See how the scanning is happening. So you start from the saphenofemoral junction. Okay, you start from the saphenofemoral junction, and after that, you are not going to remove the vein. You're going to slide the probe very gradually from superior to inferior. Okay, and each point, as you're going down, every couple of centimeters, as you go down, you're going to start applying anterior-posterior pressure. Now, what you will find here is that the orientation of the vein will go from a medial lateral orientation at the saphenofemoral junction to an anterior-posterior orientation, more caudate in the thigh, like this. Okay, so and this is a more posterior structure. The vein is the more posterior structure, and when you're applying pressure, you have to apply pressure such that that posterior structure actually gets completely occluded, like so here. Okay, and so keep sliding, apply pressure, slide, apply pressure, slide, apply pressure, slide, apply pressure, and keep going. And what you will find is that as you're going inferiorly, so long as you are scanning, you are following the vein, the anatomy, you don't have to worry about where the vein is, whether it is in a straight line, etc. Okay. Any questions so far? No questions? Okay. So for the echogenic material, so we've already covered this. Now the next thing we are going to do is to rotate the probe and see how we can put color Doppler and so see how how the probe is being rotated here. See, so just focus on the transducer. Okay, I'm going to go slowly now with the so here you have the anterior-posterior orientation in a transverse plane. Okay. After that, I'm going to go step by step, and as you are rotating it gradually, and you rotate it in such a way that the probe marker will be facing cephalad. It will be facing the head. Okay. There's nothing wrong in facing caudate. It's just convention, radiological convention. That's all. So the probe marker, so you're going to rotate the probe clockwise, so such that the probe marker is going from 9 o'clock to 12 o'clock position. And as you are doing that, the orientation of the vein. So now if you look at this picture here, it will now, the orientation will go from, or rather the shape of the vein will go from circular to longitudinal. Okay. And now I still don't know whether this is the artery or the vein, because both of them are going to be longitudinal. Okay. Now, ideally, they must be anterior and posterior to each other. Okay. So here, this person is actually compressing, and as they're slipping down, as they're going laterally, you're finding that it's the vein is going off screen. So coming back, they're getting it back. Now they've got the vein back, and now applying color Doppler. Okay, you have a very nice, beautiful filling throughout the vein here. And if you're choosing the vascular ultrasound setting, the shape of this color box will be a rhomboid rather than a square. And what this says is the machine is applying angle correction so that even if you are perpendicular to the vein, you can still have flow. It can still measure the flow to some extent. Okay, so that's why it is important for you to apply to make sure that you choose the vascular setting. Okay, so you apply, you get the color Doppler, then you put pulse wave Doppler. Okay, and when you're getting the pulse wave Doppler, you will be getting the you'll get the typical venous flow with a little bit of phasic variation. And if you ask the patient to take a deep breath, then suddenly the flow will increase. And the flow here is going away from the probe, and that's why it's coming in the negative side of the axis. Okay, but the flow is clearly increasing on deep inspiration. Okay. Any questions so far? Now, if you finish this, then after that, rotate the probe again, transverse, and keep scanning gradually. And see here, the initial line where the gel has been put is a straight line from the groin to the middle. The vein is, however, it is not a midline structure like this. The vein is actually going to go from anterior to posterior. So it has to go in a posterior medial direction. So that's why you have to have the leg externally rotated. So you have access in the lower part of this, the distal third of the thigh. You need to have access to the posterior part so that you can get to the popliteal artery. And here, clearly, as they are going to scan down here, there's no gel. So what I do, I always put gel in a wide area so that I don't have to stop scan. I don't have to remove the probe from the skin in order to put gel. Okay. So now as you're scanning, you'll have exactly the same area. You'll have exactly the same picture throughout. In an anterior-posterior plane, you'll have the artery, you'll have the vein, keep applying pressure, keep going, keep going, keep going, keep going, keep going, keep going. And then at one point, you'll find once you see the femur, the distal femur, okay, once you see the distal femur and the acoustic shadow of the distal femur, that means that you have reached the limit of your anterior scanning, and then you stop and you go to the popliteal. Any questions? Okay, now the popliteal vein, here the patient is supine. Now it's actually a little bit more challenging to scan the popliteal than the femoral, purely from a logic, from where you're approaching. Okay, so the patient is still going to be supine. You have to have the lower limb still externally rotated, and you have to flex the hip and knee around 20 to 30 degrees. Okay. When you have an obese patient, this can actually become a very big challenge. Okay. And what I do is I try and balance the thigh, the lower thigh, with my hand. So I keep my non-scanning hand under the thigh and support the weight, because often our patients are often unconscious and they don't have muscle tone. You'll either have to ask your nurse to help you hold the leg in that position, or you might have to do it. And if you want to be self-sufficient, just practice using your non-scanning hand to keep it below the lower thigh in order to support the leg in this position. Okay, the lower limb. Okay, once again, it's exactly the same. The probe is transverse. It faces 9 o'clock for both the right as well as the left leg. And you place the probe absolutely perpendicular to the skin in the popliteal fossa. Okay, and if you don't see the vein and the artery immediately, then sweep cephalocaudate until you identify the popliteal vein. Okay, so you'll have to just pan cephalocaudate and then slide the probe so that the vein is now at the center of the image, and you have to press hard in a posterior to anterior direction in order to compress the vein and look for popliteal vein compressibility. And same principle, it has to completely anterior. They have the two walls must flatten completely. Okay, so from here, okay, so we finished the anterior scanning. Now you're going to keep it posteriorly. This patient is very conveniently sitting in a chair, and therefore there's no real problem. Okay, otherwise you'll have to balance you have to use your non-scanning hand to balance the leg and hold it in position. Okay, so once you have it there, you can immediately see some avascular structure, the anechoic structure. Okay, and you know which one is which. By applying pressure, you can see that the more posterior, the more superficial one is the vein, and it's completely flattening. Okay, you have the complete flattening here, and that's your popliteal vein, and the popliteal artery is a little more anterior. Okay, any questions so far? And any questions? You can do exactly the same thing again. After that, you can rotate the probe from 90 degrees clockwise in order to so that the probe marker is facing the head, and you can get a longitudinal plane. And once again, with the longitudinal plane, once again you can apply. You can put color Doppler, and then you can put pulse wave Doppler and everything. You can do exactly the same thing throughout. Okay. Any questions? Okay. The ancillary tests exactly the same: echogenic material, color Doppler, pulse wave Doppler, everything. Now the below knee anatomy, I'm going to go into this in very short detail, but I do not scan below knee, below the knee. Therefore, I'm not an expert. But it's not difficult for you. If you want to actually practice your scanning, and if you have an extra 5 to 10 minutes, there's no problem at all. Below the knee, you have 3 veins. You have the anterior tibial vein, you have the posterior tibial vein, and you have the peroneal vein in between. The tibial tuberosity is your landmark, and you just have to scan medial to the lateral to the tibial tuberosity, and you'll get the anterior tibial vein. And as you go posteriorly, you'll get the posterior, and in between you have the you'll have the popliteal, the peroneal. Okay. So as you're scanning, 1 minute. So what you do is you just lateral to the tibial tuberosity, you apply some gel, okay, and same thing, probe marker is it's transverse facing the 9 o'clock position, and as you're scanning here, you'll start seeing the veins here, okay, and that's your anterior tibial vein. You apply pressure and it will compress fully, okay, and then after that, what you can do is you can slowly shift to the posterior, and you can get the posterior tibial vein here, okay, and see that it's fully compressible here. And then you can go in between the two and search for the peroneal vein. You can even do fancy things like, going longitudinally and so on. Don't ask me any of the anatomy. I don't know. Okay. Any questions? Okay. What are the problems when you cannot see the popliteal vein? Okay. When you're in the popliteal fossa and you just cannot see the popliteal vein, it is mostly because you have done something called auto compression. Remember that the compression of the popliteal vein is from a posterior to anterior direction. Okay, so if that's the popliteal fossa and this is the probe transducer, okay, you are going to compress in that direction towards the sky, towards the ceiling. When you have particularly an obese patient who's supine, remember that the popliteal fossa or the leg is actually going to fall down towards the floor. So if you're keeping the vein, if you're keeping the transducer there, it is extremely common for the pressure of the gravitational pressure of the weight of the leg to automatically just compress the vein on the transducer. Okay, so the alternate positions, you can try changing the position, but if you can see the artery and not the vein, all you have to do is either pull the leg anteriorly, which may be very difficult in obese patients. All you have to do is just withdraw the pressure of the transducer a tiny bit, and that pressure and that compression is gone, and you can see the vein coming. Essentially, you've actually got a negative DVT test already. Okay, you've already done the full compression. Okay. Now, if you can't see the artery at all, it means you're completely in a wrong plane completely, and therefore you just have to move the probe widely across the popliteal fossa and pan the probe cephalocardioid in order to get it. Okay, so if the vein is not compressible, then one problem might be, particularly in thin individuals, if you're applying pressure but the vein is not compressing, it could actually happen in a normal patient without a DVT. And the reason is because as you are applying the posterior anterior pressure, can everyone see my hand? Okay. As you are applying the posterior anterior pressure, the leg itself, particularly in thin individuals might actually get displaced towards the sky. So as you're pushing up, the whole foot, the whole lower limb might be getting pushed by your pressure. So you might actually need to apply counter pressure on the shin, on the knee or the tibial tuberosity with your non-scanning hand. And so that all the pressure that you are applying with your scanning hand with the transducer is transmitted 100% to the vein. Okay, and as we said, the pressure that you have to apply is to distort the artery. Okay, when the vein is not compressing, obviously DVT is your first diagnosis, but there are other differentials. If you have a DVT, you try your best to look for the other ancillary material, echogenic material within the vein, incomplete color filling, non-augmentation of the velocities, non-pulsatile flow with respiratory flow, non-augmentation from distally, etc. So try and do all of these. Okay. But the other differentials, I'll come to that in a minute. Okay. If the compressing pressure is not enough, it's your fault. And obviously, and this can happen either because you are not centered on the vein. Okay, and therefore, or you are in a slippery slope and as you're applying pressure, it's sliding away from the vein. Okay, so that's one. Then not enough pressure, so you have to make sure that the artery gets distorted. You might end up mistaking the artery for the vein, so make sure that you apply color pulse wave Doppler and look for the flow velocity characteristics. An artery will have pulsatile flow, a vein is unlikely to have pulsatile flow. Of course, when you have severe right heart failure and tricuspid regurgitation, you can have pulsatile flow, but the velocity itself will not be as high as an arterial systolic velocity. And then a lymph node may be mistaken for the vein, as we said before. You can put color Doppler. You can also change the orientation between transverse and longitudinal, and a lymph node will not change in orientation. Okay. So in summary, look for above the lower limb DVTs. Make sure the gain is good. Okay, optimal. You should not have any gain within the artery. Okay. The main thing you want to do is 2-point compression. The ancillary tests are all the other things, namely echogenicity, etc., and all the pearls and pitfalls that I talked about. Any questions? Okay, just some brief cases to finish off. Okay, so this is an example of a femoral vein, and that's the artery there, and see how this is not compressing at all. But see, I'm not very happy with the gain here. I think the transducer is a little bit crappy. However, you can see that there is echogenic material in these two structures, but no echogenic material here. And even with compression, it is not compressing. So this is clearly a DVT. Okay, the same thing in the popliteal vein. Okay, you cannot compress the, it is not compressing fully, and you can see a tiny bit of echogenicity here. Okay. Then case 2, this is again very clear cut. Okay, you have the Mickey Mouse sign, and that's the artery. You can see the wall of the artery. This is the vein. It's communicating. Can you see how the vein and the saphenous vein and the femoral vein are in communication with each other? Whereas the artery, you can actually see a physical wall between the two. And then within the vein, you have a mixed echogenic lesion or mixed echogenic structure. So, and that's not clearly, that's an ancillary thing. When you're applying pressure, the artery is getting distorted, and the vein is just not compressing. Okay. Then another one here. Okay. So again, look at that in the saphenofemoral junction. In the you have lack of compressibility, and you have the echogenicity. So all of these are very, very clear cut, and always recognize this wall of the artery to make sure that you're not, you're not mistaking the artery for the saphenous vein. Okay. And then what's happening here? Can anyone, where is the reason I'm pointing this out is because this person actually mistook the superficial vein here as their object of interest, and they said that structure is getting fully compressed, and therefore there is no DVT. Okay, so they mistook the superficial structure. The actual area of interest is in a corner of the screen. It's not in the middle of the screen, and that's actually not compressible, but it might be because there's not enough pressure being transmitted. So what they should do is to slide the probe more medially and get this structure in the middle of the screen before they repeat it. Okay. So you don't want this structure here to be, that's a very superficial tiny vein, and it's hard not to miss this big blob here, but unfortunately this person did. Okay. Then this is another thing that they mistook for a lymph node, but when you're doing a longitudinal scan, it's actually it was actually a vein. It was nice and longitudinal, and therefore it was misunderstood. Thanks, guys.
Thank you, Arvind.
Thanks.
Thank you, Arvind.
Bye.